So we're going to start now. My name is Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation, otherwise known as JOEI. We will be talking tonight about complex proximal tibial plateau fractures and maybe a little bit about distal femur fractures as well, and whether to repair or to replace, and what novel techniques people may or may not use for this very difficult and challenging operation. I'd like to introduce the panelists for tonight. I'll start with Matt Barber. If you'd like to introduce yourself, please, Matt.
Matt Barber. I'm a community knee and hip arthroplasty surgeon down here in LA.
All right. Mike Langworthy.
It's Mike Langworthy. I'm chairman of orthopedic surgery, coastal Massachusetts, retired Navy captain, background in both trauma and adult reconstruction.
Sure. Daniel Allison. Dan?
Hello, Daniel Allison here. I'm in Los Angeles. Middle name is Chris, Christopher, so my friends call me Chris. I'm an orthopedic oncology specialist, and but I did a lot of trauma. I trained at LA County USC. Also Navy, but in the reserves. I'm currently at in Nashville at Society of Military Orthopedic Surgeons annual meeting, and appreciate you having me on board.
Thank you. And Nick Arnold.
Thanks, Ira. Nick Arnold, fellowship trained arthroplasty surgeon in the community, kind of like Matt, Fort Wayne, Indiana. So hip and knee replacement and using a lot of these technologies for the more complex stuff, which could be fun.
All right, excellent. So let's lay out the groundwork here. What are we talking about? What type of cases are we talking about? Michael?
All right. So, yes, starting about 19, there's a 1% drop in your bone density as you age, and it comes down to weakened area pathologically at the metaphyseal diaphyseal junction. You get these fractures through that area, either native or prosthetically, and they can be very, very difficult to deal with. So one option is open reduction internal fixation. Another option is joint replacement. As a chairman, I am very interested in cost containment, and I've got a trauma program here, and we've had issues with folks that have underwent open reduction internal fixation with a subsequent return to the OR to definitively refix or to replace these joints.
So, Chris, when you see these fractures, how much bone loss do you think how do you assess the bone loss, when you make your decision making in this?
Well, I think we've got to divide it into the different groups, but certainly in the elderly osteoporotics, that's one scenario. I don't think this is something we're routinely thinking of in the younger patients. And I'm mainly here as a conduit on the joint side. I'm oncology trained, but I end up doing, as an oncologist, you basically take the cases that nobody wants to do, infections and things, and a lot of revision work. So I see it on the cases of periprosthetic fractures.
Right.
And as we get into the nitty gritty with this, I'd love to explain what my thought on it is. But I get some of these cases where they have a very high periprosthetic fracture around the tibial implant. There's a lot of stress shielding in the area. So on top of their osteoporosis, their bone is shielded. And you may be putting in plates, but they're not fixing in anything. You're basically just putting in ornaments. And then you might as well not do anything. So I think this is intriguing. This area, but I think we've got to divide it. And my thought is that this is going to be like a new paradigm, similar to the DFR paradigm with distal femur fractures, because it all started with periprosthetic fractures on the distal femoral side. They already had a joint in, might as well replace it with a hinge. And then pretty soon they said, wow, these elderly patients with a periprosthetic joint fracture and distal femur do pretty well. Now they're talking about doing distal femur replacements for routine distal femur fractures with no prosthesis inside. So I kind of think the way we're talking now, we could establish a new paradigm on the proximal tibia, but it's going to start with the joint replacement side. But I do think we need to stratify these patients and see. I'll bring it to Mike and say, are we talking about even young patients with a blown out Schatzker 6 who are 45 years old? Or are we really reserving this for the elderly osteoporotics?
Mike?
We've done these as the hinge prosthesis for folks as young as their early 50s. And you'll see one of the videos on how it can be done and how you can optimize mechanical considerations and turn this into a fairly good not only hinge joint replacement but a rotating platform. So we'll run through that here in a minute or so.
Yeah. Nick, what's your experience with this?
I would say that there's a lot of times when things are coming down my way, it's much more of a poor bone quality scenario, and the ability to replace is usually why somebody's been sent to me. So there have been cases where I've even witnessed a small chip or a crack in the tibia when I'm doing a distal femur, and then 15 minutes later, as I'm trying to put in small frag screws and I'm not very satisfied, I think, man, maybe we need to be doing this proximal tibia too. So I think there's a lot of power in being able to use a large arthroplasty system such as these.
Yep. Matt, I'm going to say when I was your age, when I was younger, when I was younger, we used to believe you have to put all this bone graft in, put all this the screws in, reserve bone loss, all that bone loss, preserve, reconstruct and get good bone, and then come in later and do a joint replacement. What has allowed us to sort of abandon that a little bit? What do you think?
I don't know that we have. It's a really interesting topic, and for a community arthroplasty surgeon, we certainly have a selection bias of seeing patients with proximal tibia fractures subsequent to that. And I think the thing that's so interesting about this to me, there was another JOEI topic session on hinged knees,
Yeah.
and was fascinating to hear Michael talk about this, of sort of the algorithmic approach to this, of really backing up and looking at these patients very holistically, really, of what are we doing with our solutions, where you have patients that have these injuries and they may have a protracted period of non-weight bearing, and then they may end up with arthrosis anyway, and then they're having a subsequent arthroplasty that may even be staged depending on what sort of procedure they had in terms of surgical approach and hardware, and does somebody feel good about doing an arthroplasty in that situation, or removing the hardware and taking cultures and then coming back. So you really have these, as Michael alluded to, very expensive episodes, and episodes that are insanely disruptive to these patients' lives. So I think the ability to step back and kind of think about these problems and how we might solve them on a very patient-centered level is really interesting. And I think some other people have touched on sort of moving from what we've seen with DFR, particularly periprosthetic fractures, but just really comminuted distal femur fractures as well, where they were, they were unfixable. There was not enough quality bone to even put screws in and have it hold anything together. And so this is what we had to do. And, gosh, they work really well a lot of times. So it's interesting to see that shift a little more distal.
Yeah, it's great. I'm going to see about bringing up this screen. Here we go. I'm going to share this screen. All right. Hold on a second. I don't think I'm sharing. Now you can see. Can you see my screen? No.
Yeah, we can see it.
Excellent. Excellent. So this is everybody here. You guys have great headshots. I'm going to say fantastic. Mike, you want to take us through this?
Yeah, so let's go back and kind of look at the whole person, as Matt was pointing out. So in this case, I'm creating a fracture pattern. And we talked a little bit about how there's some pathologic morphology at the junction between the metaphysis and diaphysis. Now, when you have injured bone, it switches from an endosteal perfusion mechanism to a periosteal perfusion mechanism in that first 24 hours. There's a lot of proteins expressed, including bone morphogenetic protein. There's a lot of components of inflammation with both wound healing and wound immunity all being set up in that first 24 hours. In this case, we're going to create a fracture at the metaphyseal diaphyseal junction, and then instead of taking all of this bone out, we're going to pot the prosthesis, and that's something that United's gotten interested in, and Dr. Allison and I are working on a hinge prosthesis that is going to allow the bone to anneal to it. So instead of doing a prosthesis where you take out all the bones and the ligaments aren't attached to anything, you leave the bone in there and you get the bone to heal either via scar tissue or endosteal connection to the prosthesis. Will that run, Ira?
Yeah, it's going to run.
Okay.
Here we go.
So even at the outset, who's this patient? I mean, obviously this is a cadaver, but
yeah, it's cadaver. Yeah.
What's kind of prototypical? I mean, what age, what kind of injury are we looking at?
So with a native fracture, the folks over 70, we have moved towards simply replacement with basically no attempt to do a ORIF. We talk to the patients and let them know that, look, we can attempt an ORIF on you, but it's likely going to be 6 or 8 months before you're actually walking on this. The average age of patients having their first healthcare crisis in the U.S. is about 63. So people want to enjoy their life, and we can explain to them that we can do this. We can do this with literally a primary adverse event profile rate, and they can walk on it and they'll walk out of the hospital, so to speak. So it's folks basically over 70, but we have went younger.
So I'm going to run through the video now, and then I'm going to ask Chris Allison to talk about the implant and some other things. So, Mike, we're splitting the tibia here, right?
Yep, creating a couple of you see, you left the plateau. We're going to pot this thing right in the middle of it, right. And then we'll end up cabling the portions of the cortical bone actually to the implant. Okay,
let's look at that.
Do you saw cut that posterior cortex of the tibia with the vertical?
That's a great question. So actually, most of those fragments, those cortical fragments, have already been created for you. So you could take a curette or a rongeur and just take off the residual metaphyseal bone, but I leave that posterior cortex to protect those posterior neurovascular structures. You leave the medial and lateral plateau so that there are ligamentous attachments to the plateau. So it actually becomes a much safer surgery instead of peeling out all that bone.
Okay, so let me just continue a little bit more. Oops, sorry. There we go. So you're wrapping this around. You're putting these cables. I'm going to ask some questions about these cables in a second as well.
All right.
But that looks like the construct and the cable.
And you can see the bone is now covering up the construct, which is immunologically and from a infection standpoint, that bone is another barrier to infection. So this drops your infection rate for these, which can be fairly substantial, down to what you would with a primary knee arthroplasty, by leaving the bone intact as a barrier to infection.
So tell me about the cables you're using there.
So those are the Kinemed Super cables. They're a filament cable. The United the prosthesis that I'm putting in there is now developing a relationship with them so that the cables and the prosthesis are sort of married up to one another.
Wow. This Great. Chris, I'd like you to talk about, I'm sorry, let me just stop my share for a second. Let me see where everybody is. There you go. Chris, talk about the value, the value of how implant technology has grown and what you're doing now in mega replacements and mega prostheses.
Great question. I think, the mega prosthesis has been around for a while, since the Stryker GMRS, which, 40 plus years,
Yeah.
does great. But everything comes down to the insertion and insertional attachments, whether it's on the greater trochanter or on the proximal femur, and with the proximal tibia. And I think that's an area of great gains. Most of it now is just looping in cerclage cables and going around, but I think there's a way to actually bolt directly into the implant and do it well. Zimmer's got a decent prosthesis, but I know United, Mike and I've been working on this, that we're hoping to take it to the next level in terms of making you feel very secure about your tibial tubercle. That's the big thing that turns people off on trying to replace a proximal tibia versus being very amenable to replacing a distal femur. But I think with good enough implant technology and securing with compressive fixation, whether you have a shell of bone or not, preferably you have a shell of bone. I agree with Mike. You want that extra layer of biologic fixation or biologic coverage. But even with straight tendons, I think with good implant technology, porous ingrowth surfaces, that we can compress tendon down to implant and get reliable healing. And to me, that's the most exciting part. And then the second is going to be antimicrobial surfaces. We all know that endos get infected much more than normal, than traditional implants. I think that's some degree related to the surface area, which is obviously more in an endo. I like the idea of guerrilla warfare and turn your weakness into a strength. So that surface area that predisposes us to infection, if we can coat it with a silver or some sort of other covalently bonded antimicrobial, we could potentially, ward off infection and add that to make this much more amenable.
All right. Let me move on a little bit and get some opinions from Nick. Nick, what's your experience with this line of implants? Yeah.
I mean, it's a good product line without obviously being too biased towards a certain manufacturer. Just know that this is an implant system that is simple enough, but it allows you to take care of complex cases in a simple fashion. I think that's very important, because by the time a case like this is going to get to somebody like us on the panel, you're looking to maximize function, minimize time under anesthesia. The longer the wound's exposed, the more your infection rate is going to go up, and the implant system is strong in that regard.
Okay, I'm going to share my screen and just have my comment on this. You see, I know you can see my screen here, right?
Yep.
So take us through this whole. This looks like an amazing construct. I'll tell you honestly, but tell me about.
With the biologic proteins that are expressed with the fracture, you have these bone morphogenetic proteins which will differentiate certain cells into one of 8 cell lines, including bone, ligament, scar tissue. And we found that by putting that cortical bone back over the prosthesis, it does markedly reduce infection. And then the side effect is the ligaments are attached to it. So the scar that may heal to the bone, to the prosthesis, it's about the same tensile strength as aluminum wire. So whether you get full cortical healing around it, and we've had those. I've got some nice pictures of the hinge prosthesis becomes the new metaphyseal surface, but the combination of bone and scar and ligament makes for a very stable prosthesis with its own kind of built-in immunity.
Matt, have you had experience using this technique yet?
Nope. I'm here learning.
Unbelievable. It's great. Yeah, this
It
is.
really is.
How long has this technique been around?
We've been doing it here for about 3 years. I mean, we had I had my trauma guys do one. They spent 30 grand on a catastroplasty, and it all fell apart. And I ended up going back and doing a hinge. And then I started looking at some of my old data. I had a lab basically in Thailand, and Chris is kind of familiar with that. So we looked at what is occurring with inflammation, wound immunity, wound healing. Even the bone, the pain fibers will retract after about 3 weeks. So the bone, these chips are no longer painful. I know when I've seen tumor guys do this, typically they take out all the bone and it looks very clean on the X-ray. But from a mechanical standpoint, from a immunologic standpoint, you're compromising some of the tissues that could be left there that provide structural integrity as well as wound immunity.
Okay. Chris, could you talk to me about the patella tendon and in this construct? What challenges you had, or if any, you know?
Yeah, I think it comes to that's obviously the big concern when doing this. But if you think about those of us who do a lot of revision work with knee replacements, not uncommonly, some guys their go-to is the tibial tubercle osteotomy and taking out. So bringing it back together with an implant, they've got good ways to do that. And there's a number of ways to do it. I'll get into it in a second. But what you have to realize, as opposed to the distal femur, the anatomy of both the bone and the fracture is totally different on the proximal tibia. Distal femurs are going to break in the metaphysis above the epicondyles. So if you're going to replace that, you're automatically taking that epicondyles out. You have no collaterals. Remember on the tibia, the LCL attaches to the fibula, not the tibia. So pretty much almost uniformly on tibial plateau fractures, you're going to have an intact lateral collateral ligament. I think that's a game changer. And then if you go into what Mike does, which is awesome, which is he preserves all that tissue around, you're preserving the medial sleeve and a medial sleeve of tissue. You've got your MCL too. So really we're talking endo, but the endo is for the bulk. You don't actually need the endo for the hinge because you've got your collateral, at least one collateral. A lot of times I would argue two collaterals. So now you're talking about being able to put in a PS and a non-stemmed femur. And I think this is where we'll really change the game if we get this out there. And then I think United has been so great to agree that, you know, we're gonna create this proximal tibial endo, take what they have now, which is already awesome, and take it to the next level, but be able to put in a rotating platform smooth that can be a PS, a PSC, or a CCK. And then you're going to have somebody who's maybe they're not comfortable putting in a CCK with a stem on the femur, but they could sure as heck put in a normal PS femur. And I think that's where it's going to get really exciting, and we'll change the game on this.
So what are your, right now, what are your articulating options in this system?
For the United system?
Yeah.
Well, you could easily use the United, their standard revision system with a stem and pot the stem and put in the CCK or even a PS.
Oh, okay.
As a fixed bearing, which I think is perfectly reasonable. Just nobody does this because nobody's thought about it enough, but you don't necessarily have to jump to it. This is definitely good when you have no bone to deal with whatsoever and you want to have just a stable cortical platform.
Right. Let me go to the next slide. I want to show this video. Mike, tell. First of all, it's kind of a quick trick question. Is this patient the patient with this implant?
It is, yeah. So 3 months out, 50. I think she's 54-year-old nurse, back working now. So a devastating fracture. The thing that we're working on now, that Chris and United and I are working on, is a smaller segment that medial lateral, but also a little bit shorter, so that you don't have to do that 67 millimeter cut and pot the thing. So we're looking at the bone pathology, the bone anatomy, and coming up with a prosthesis that's somewhat individualized for that particular pathology. So she's using this as basically a primary knee.
Wow.
Now, and if you look at that extra, you can see all the multiple points of fixation. If that tubercle heals to the shaft, you're golden. If it heals to the implant, you're golden. if it heals to the medial and lateral bone around it, you're good. So I feel very comfortable. I can see why she's walking so well, the way you fix that, Mike.
Yeah.
You know, that's
Well,
got
Matt had commented earlier about the posterior aspect of the bone, and I leave it. It spares those vessels. You're unlikely to damage those vessels if you have a protective bone covering abutting up against the implant. And just to clarify, I do the same thing on the femur. So we take a saw, take the epicondyles off, and put those back on when we're done. So it becomes very safe, a very expeditious procedure by understanding the anatomy where the nerves are. But we don't, I just take out the metaphyseal bone and leave that cortical bone with those ligamentous attachments.
It's fascinating. Nick, have you tried this operation before?
The distal femoral aspects, absolutely, but I
Yeah.
yield to Mike and Chris for the proximal tibia aspect. It's certainly impressive.
So when you do the femoral side, which is I think our next topic, um, what you wrap around the condyles as he said? What's your technique on that?
I have not. Go ahead.
Anyone could take it.
So I take Ira, it's Langworthy. I take a saw and actually take off a wafer of bone on the metaphyseal aspect of the femur, and also there's usually a posterior shell of bone. And like I said, we just leave it. So you take out the diseased metaphysis and pot that thing right in the middle with the cortical bone left to. Currently, we don't have a good way to attach it because that's a smooth surface. But as we get more knowledge on these surfaces, we may be able to reattach the condyles right to the prosthesis, turning it into a metallic metaphysis, so to speak.
All right, we have a question from Kevin Plancher.
Hi, all. Really impressive, Michael and Nick and Dan. So tell me about what do you do for antibiotic coverage with these things, infection, and then how are you maintaining the joint line? How are you knowing where to go?
Anyone?
Yeah, go ahead.
No, you got it, Mike. Yeah.
Okay, so since we've left the bone in, I'm using our typical antibiotic prophylaxis. So, Ancef, if they have MRSA in the nose, they get the addition of Vanco. We've started using interosseous Vanco on a number of our total joints now. And then if they're immunocompromised at all, we do 2 weeks of postoperative PO antibiotics. And the joint line's a great question. To kind of use the fibula, the head of the fibula, if that's left intact, then we do about a thumb breadth above that.
Thank you.
Yep. Have you got either of you gone in on these? Let me stop the share for a second. You don't need to see my emails. Okay, there you go. That will be edited out rapidly. Have you, for any reason, reopened these, revisit it? I'll ask both of you, what did you find? Whether it was for infection or for something. Have you revisited these and, what have you found?
In our program, we had a lady that had previous quadriceps pathology, and she ruptured the quadriceps tendon off of the prosthesis during physical therapy. And I had to go back in, and the bone was competent, the cables were competent. The scar tissue was, like I said, it's like aluminum wire. So whether you're 9 or 90, the genes that make bone, the genes that make the scar tissue are actually pretty conserved, and they will make a robust a type of biologic material when it's all said and done.
Dan, Chris? Yeah.
And I want to piggyback on Dr. Plancher's last question about the joint line, which is very good question. So a couple things when I do with that. One, if you're doing a distal femur fracture, say a native, I would just do a skim cut on the tibia so that that's your basic platform. And then I prep the other leg into surgery. And I think that's very important because it's so easy to get way off in limb lengths. And as long as you've got, reasonable tibia,
Right.
then you basically tile it in. And then of course I double check. And the beauty of a hinge is you don't have to balance in flexion, right? And so you're in extension and you know where the patella is. And so I think prepping the other leg in, just like with an anterior approach off table, is essential for this. And you'll avoid a big limb length discrepancy, and you'll get your patella where you need it. And then in terms of antimicrobial, I do a lot of irrigation with antiseptic solutions in surgery, and then the routine, as much antibiotics as I can give post-op on that. But repeat your question again, Ira.
When you've gone in a second time for any reason.
Oh yeah, the second time when I've gone in has been for aseptic loosening because I was big on using 80 millimeter and 90 millimeter stems, and I'm getting off of that now. So I used to think like, oh, if I want to come back, I want to make it easier to take it out. I'm going 125, 150 fully cemented on stems for now on.
Very good. Marty Nichols, you had a question.
Yeah, if you're reattaching that tibial bone and leaving the ligaments in place, I get the fact that the hinge takes the load, but how much focus do you put on the balance of those ligaments to ensure you're not over tensing them or creating pain receptors when you reattach that bone?
Great question. From what I've seen, the pain fibers sort of recess within that first 21 to 30 days. As as one of the balancing techniques, since the cortical bone is left there, I can actually look and see where the joint line was, intraoperatively. So the leg length, accidentally lengthening the leg has not been an issue because that cortical bone is still there and it's like a piece of a puzzle. I'm back at the original joint line before the patient even had the trauma. So by leaving that cortical bone there, I know where it was, before we started, and I can balance around that.
Great answer. How many different sizes does this tibial replacement come in? I'm just curious. I'm kind of getting at the idea of, are we eventually going to be replacing the need for custom implants, in this area? I don't, does it come in just one size right now or two sizes? What's the options?
Peter Waterman, are you on the call? Can you chime in?
I am currently one standard size and one pediatric size, and we're considering other options too.
And really, you don't need much. You don't really need a big size. You
Right.
definitely need a small size because there's times where it can be very difficult to close. There's some people that argue that you need to rotate a gastroc to cover a proximal tibia. I don't think you have to rotate a gastroc every time on a proximal tibia, but sometimes if you've got a big tibia and a small person, it can be very difficult to bring those together. Whereas I would have no problems putting a small size tibia on a 400-pounder as long as I fixed it well in the diaphysis.
Okay. What are some of the biggest challenges during the case? I mean, in that cadaver example, it looked pretty smooth, but does it always go that smooth? What happens when it falls apart, if it falls apart? And some comments on that. Anyone on the panel or anyone else want to take that on?
I think that's the beauty of the endo. That's a little secret. I guess we'll just let in on anybody who's watching now because they think in the oncologic world, like we do all this really tough stuff. It's so much easier to put an endo in than it is to put in a regular knee. Because you've already made up for everything. All you have to do is put it down the canal and put it at the right length and in the right rotation and secure it securely. The metal does the rest. So I think you're already in a spot where you're safe, but that's my take on it.
Yeah. Michael?
Yeah, I would echo that.
That's great. What other challenges do we have in these kinds of cases? And I think what I'm getting at is decision making. Again, let's go back to what we started with, sort of the decision making of who gets this or not. Where is your threshold, Chris, the same as Nick's, or the same as Matt's, or the same as Mike's, or could we eventually all agree on a threshold on what fracture gets the endo?
I think it's too much of a gestalt to put those kind of guidelines in. I think it depends, obviously, number one, on the patient, and every patient is a little different, even though we do categorize them. Certainly, the young active patient is different than the 95-year-old. And then it depends on the surgeon, because we've got some guys who are purely trauma trained, and they're going to do great with metal, with plates and screws, and other guys that are joint trained, and they're not going to do an oncologic joint, that they can do it with a regular revision. And then you have those of us who are versed in the megaprosthesis, which we'd rather just cut to the chase and get the case done in an hour. So I think there's no good, easy guideline, but it's this gestalt that we need to start talking about all the different patients, all the different surgeons and their skills, and really hone it out from there.
Ira?
Yeah.
Ira. So Dan, I mean, that was well said, but a Schatzker 8 still gives you arthritis in 6 years. It's not like 20 years. You have to wait in the best hands when you're putting it together. So I think I would ask you, because you and Michael and the group are to come up with an algorithm, and then let's put it on the stage and let's fight it out, with the trauma surgeon going up against an endo, and have the algorithm so we can get it, to have more conversation. Because Bertie Morey started the equivalent, I think, when he said put a total elbow in a 65-year-old that had a distal humerus comminuted fracture, and they boot him off the stage 14 years ago. But the upper extremity surgeons are now throwing total elbows in these people and saying, I can't fix it as well. So you're really doing the same thing with the joint. Bravo. And thanks to United and other companies. So I think it's worth it to put the flagpole down and say, this is what we think our algorithm is. I would encourage you.
Will do. I think you're right. I think we should at least start talking about it. We don't need to do anything hard and fast, but it involves looking at the patient, obviously, and then the surgeon.
Right.
Skill.
Yeah, maybe there's some kind of course you could present this at. I wouldn't know the name of any particular course like Ortho Summit or something.
Just so I do it publicly, because Ira knows, but others may not. I have retired from it and turned it over. So I was being sincere about an algorithm to do it, because I think you got something really great.
Yeah, no, absolutely. Nick, what is your threshold on this kind of stuff?
Anecdotally, a lot of times the decision is made for me. I'm lucky to be in a practice with a couple of trauma guys, a couple of joints guys. By the time it's coming across my desk, it's for a specific reason. And a lot of times it's to use the endoprosthesis. So I'm spoiled in that regard. But to jump off of what Mike and Chris were saying, a lot of times if I had to make the decision on my own as to where to funnel the patient, really come down to the patient's function, their overall medical frailty, and then make a decision.
Yeah, Matt, how about you?
Yeah, I mean, I think it's probably you've got Mike and Chris that are pretty versed with this, and I suspect that that this will evolve kind of the way DFRs did, and early on that was for just the unfixable fractures in the very elderly, lower demand, and that kept growing, and so it'll be that gestalt of initially of there's just nothing else we could do with this. This is what I got to do, and then surgeon comfort and more learnings about that will probably lead to the increased adoption and the increased indications. To the guys doing these and to the panel, your diaphyseal fixation, all cemented, or are we usually putting a cable at the opening? Does anybody put a cone in the opening or done anything with that? And what are you doing with them post-op in terms of weight bearing or any immobilization?
It's like, so I often do a prophylactic cable around the coracal bone. I've cemented almost all of the stems that I can recall. So immediate weight bearing. And as Chris has pointed out, if you've got great tubercle fixation on the patella, you can go pretty fast.
Yeah, I've been cementing as high up in the diaphysis as possible, a cone if I've got that ability. And you just know that if you're going to be cementing mid diaphysis or press fit, you're going to get end of stem pain. And so I'd use a smaller diameter stem if possible and be ready for it.
Interesting.
Are you cementing the stem, or are you putting a cement restrictor all the way and really pressurizing it? And
yeah, put the cement restrictor in and yeah, pressurize all the way and
real cemented stem. Yeah.
yeah, not just just sliding it down like on a revision knee. It's a revision. It's a real cemented.
Tough to take out. Yeah, meant to stay in. Meant to stay.
Hope you don't.
Yeah, that is true. That is true. Do you think so who's going to be doing these in the future? The joint surgeons, the trauma surgeons, or the oncologic surgeons?
Well,
That is a great
yeah, patient trauma is going to change. So you're a computer guy, Ira, and with the collision avoidance technology on the vehicles, the cars aren't going to be able to hit each other, not going to be able to hit pedestrians, they're not going to be able to hit other motorcycles. So the face of trauma probably will change in about 80 to 100 months as we go towards this more sophisticated automotive type availability. The next wave of trauma is going to be low energy falls. So as your chair of your program, there are certain attendant costs with both prosthesis, length of stay in the hospital, the surgical time. So this sort of moves into more of a arthroplasty or a move towards arthroplasty as far as the economics of this goes.
But just like sports surgeons, as their population gets older, they all of a sudden become knee surgeons. We're going to see your trauma surgeons becoming arthroplasty surgeons.
It's actually interesting. The technique is pretty simple, and as Chris mentioned earlier, you're doing these in about an hour. About an hour. You do a complex tibial plateau fracture, like 3 to 5 hours, but this can be reproducibly done in about an hour.
Yeah. And I think that brings up a really cool change in the potential paradigm where even the trauma guys are starting to do more cases, the so-called traumaplasty. And I know the OTA is kicking back against that. But if you go outside of America, they don't just pick a specialty like I only fix fractures. They pick a joint, right? And there's a knee guy in the East, and that guy does ACLs, he does unis, and he does knee replacements, and he does revisions. All he does is the knee. Now, granted, we're different, but I think if you want to be, as we get better and we have technology like this, like what United is bringing up, you have to be able to. If you're a trauma guy, you're going to have to be able to put in a revision knee or an endo. And if you're an endo guy or a joint guy, you're going to have to be able to fix at the time when you need to fix. And so I think we're up at an interesting time, and I think there's going to be pressure because more of these young guys coming out, they want to be able to do it all and not to be just pigeonholed in one area. And I think it's up to us to kind of get the pressure on the OTA and try to get more arthroplasty into trauma.
Oh, it's a great point about what they do in Europe. There was I think there still is the ISK fellowship in New York. It was really a knee fellowship where people did knee replacements, ACLs, menisci, and did that. We may see more of that as this comes on. What's the future of the implants? What's coming down the line? What's your wish list of, because everyone on this call has been doing this for a while, and you use an implant and it's great, but you have a wish list of what you want the next implant to look like. So, without giving up NDAs and stuff that's behind the curtain that Carol Merrill is now standing, if you remember Let's make a
Come
deal.
on, Ira. Not everybody knows who Carol Merrill is.
I know, I know, I know.
Come
Uh,
on. I guess none of them by
None of
now.
them do, but game show hosts, but um, what's your wish list? What's your wish list? Let's ask all the faculty. What's your wish list on where this is going? Let's start with Mike.
I think we should pay attention to where the fractures are, and then design an implant that seats right in there with variable stem options and variable medial lateral anterior posterior geometric configuration with coatings to help annealing bone onto the implant and antimicrobial as Chris had mentioned.
Yes, Matt, what would be your wish list on this stuff?
Ingrowth surfaces for bone, certainly antimicrobial things. I don't know if I'm wishing for it yet, but I'm watching. I think if you look at the success of fluted conical stems in the proximal femur, both monolithic and modular, that would be very interesting. Upgoing in the femur or into the tibia. Now, you know, those come with problems if you ever have to get it out as well. But really, cementless fixation could be interesting here as well.
Nick, what would be your wish list here on these kind of implants?
United's obviously created a great product so far, and you can see evidence of this panel that it's applicable in many situations. But if I would think of something specific, almost looking at what Matt's saying too, the bone implant interface is essential, even in a comminuted fracture. So I think where that stem meets the bone, especially even if you're cementing it, some implant systems have a larger, almost ovoid shape that allows for a lot of contact with the cortical bone where you made it. A lot of times I find myself almost trying to take a level of bone cut that allows me to have a nice flush surface where it's occluding right on the bone that I cut on that implant. I think if you had some modularity at that bone implant interface, maybe even an ingrowth type material, that would be something that make me sleep at night a lot better.
Interesting. Chris, some wish
Yeah,
list?
I don't have anything novel to add because they touched it all. But yeah, definitely antimicrobial surfaces. Covalently bonded silver, I think, has already been shown with the Gluna in Europe with endoprosthesis to reduce infection by 50%. The FDA is very much against it, maybe from the metal on metal fiasco. I think we've got to really push that through. And then nano scaffoldings I think we can do better than TPS in terms of getting reliable ingrowth, not just of bone, but also of tendon. Sometimes you don't have the bone, and to get that tendinous, if we could reliably get a tendon to heal to a titanium implant, I think that would be a game changer. And then Matt's idea of conical stems, of spline tapered stems to go into the tibia, I think is a great idea, because universally you're going to get end of stem pain with either cemented or press fit stem in the mid diaphyseal tibia, or not universally, but I get it a lot. So perhaps a conical stem into the tibial diaphysis could get good engagement and not have that end of stem pain.
I think that's a great idea. And Matt, I just grabbed the website tibialconicalstems.com. So if you ever need that, it's going to be okay. So let's sum it up as most Joey sessions, it goes by in a blink of an eye. So I want everyone to give thought to what they're going to say as a sum up, and I will start with Nick. Okay, so sum up of what you think, just sum up of the problem and some final words for the many people who are going to follow this afterwards.
Sure. Just say thanks to everybody, especially the panelists, Mike, Chris, being able to provide their insights, key, especially for this indication. But I'd say these are bad problems, but we have good solutions, and the solutions are getting even better thanks to products like United's putting out. And you may certainly see a paradigm shift. Like Kevin has mentioned, there would be a need for a more algorithmic approach to this, and ultimately it's going to be good for patients. That's what matters.
All right, Matt.
as often happens, I'm just the interested observer, standing around with some very smart surgeons. But these are really bad injuries, and really bad problems, and it's so very interesting to really, I think, be on the precipice of a paradigm shift here. And what Michael and Chris are talking about is really interesting in ways that can really move the needle for patients, and make their lives better and improve kind of what we're doing, as a system. So it's exciting to see, and it's great to have prosthetic options like this. United really has done a wonderful job with that entire platform, and to be able to mate a proximal tibia replacement to a hinged femur that really doesn't remove any bone, barely more than a posterior stabilized knee, is neat. And it's exciting to see this, at least the early part of what may be a transition.
Chris, some final comments?
Everything all figured out. I think there's plenty of room at the top and plenty of room to make things better. And I don't think we need to be restricted by dogma. And so I think this is one of those cases that we could change the paradigm. I think it's going to start by using it in the periprosthetic world of routine knee replacement, where people can see that you can replace the tibial component, even leave the femoral component and not have to fix it. And then from there, we're going to graduate and eventually be doing this routinely in dusted proximal tibias without a joint replacement, at least in the people over the age of 50.
Great. And we'll have the former Navy pilot bring us home.
So I think Dr. Allison and Dr. Blanchard had two really valid points. So one, it's got to be patient specific, and two, we need to come up with definitive algorithms. My algorithm right now is if you're over 70, this is what you're going to get at this point.
It's great. So we're at the end. I want to say a big thank you to the panel and to the many questions that people asked. This is recorded and will be within a couple of days on the JOEI website, the YouTube channel, Spotify, Apple Podcasts, and available everywhere. So any trade secrets are now no longer. So we're there. I really sincerely want to thank everyone for tonight. Remember, Wednesday night is spaghetti night in Boston, and it's Joey night on the internet.